Hi, everyone. We'll give everyone a moment to make their way in. I'm using two monitors tonight. That's interesting. Okay, let's see. Welcome tonight, everyone. This is a very special event. It is tonight's last Woo You event for 2024. So it is such a great honor. I think I might have done the first one for 2024, and now I get to end the year. What a year it has been here at Woo You. I just want to share a few stats before we get started, because as people make their way in, there have been about 64 hours of CE shared this year with Woo You, which brings the overall total to about 288. In 2024, there were 51 events, and overall Woo You has done 212 events. In 2024, there have been over 59,000 CE certificates processed, so that's why we say give it some time, because there are so many of you attending. And that brings the total to over 218,000 CE certificates that have been issued from Woo You. The largest event was Dr. Vin Dang with over 1,900 attendees. That was the largest event for 2024. And the most prolific presenters were Dr. Tracy Offerdahl and Dr. Selena McGee. They both had presented the most. Just a reminder, if you haven't already signed up for the Cozy Pharma weekend on January 11th and 12th, there'll be 8 hours of CE for that weekend. So you can find that on the Woo You website. We'll share that at the end, but that's going to be a great event. If you're like me in the Northeast and you're stuck inside, it's a great way to get some CE while you're cozy at home. So without further ado, welcome to tonight's Woo You presentation, Ocular Surface Disease Diagnosis, Treatment and Real-World Patient Communication with Dr. Mark Blumenstein. I'm your host, Dr. Jennifer Stewart. Thank you to Avanova for exhibiting at tonight's event. So just some reminders, for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks. And throughout the presentation, feel free to ask questions using the Zoom on-screen floating panels. Tonight, we actually are changing it up a little bit, and actually we'll be moving to the next room to actually do the Q&A. So you have the option of asking your questions here, and I'm going to be collecting those. If you are afraid you're going to forget, you can put it in the chat and Q&A, and I'll be collecting those throughout. But we're actually going to be doing the Q&A in a separate room tonight. So if you want to hold your questions there, we can do it there. But if you're like me and you're afraid you forget, you can put it in the chat and Q&A, and we'll get to as many as we can. If you're on a mobile device, you can find the Q&A at the top, and you can find chat in the mobile behind those 3 little circles. So it is my great pleasure tonight to introduce Dr. Mark Blumenstein. He's a graduate of the University of California at Los Angeles with a degree in biology. He received his optometric degree from the New England College of Optometry. After graduation, he finished a residency in secondary ophthalmic care at the Barnett Delaney Eye Center in Phoenix, Arizona. He then received his fellowship from the American Academy of Optometry. Currently, he's the Director of Optometric Services at the Schwartz Laser Eye Center in Scottsdale, Arizona, and President of MRB Eye Consultants. He's on the editorial board of Primary Care of Optometry News, Review of Optometry, Optometry Times, Modern Optometry, Optometric Management, and is a frequent contributor to other various optometric journals. He's also the chairman of the Education Committee for Vision Expo. He served as chairman of the AOA Continuing Education Committee and served on the board of the Ocular Surface Society of Optometry, as well as a founding member of the Optometric Cornea, Cataract, and Refractive Society. He has served as the president of the Arizona Optometric Association, legislation chair, and president of the board of the Arizona Optometric Charitable Foundation. He has delivered over 1,500 invited lectures worldwide and serves as a consultant to numerous industry-leading pharmaceutical, biomedical, and informational technology companies. It gives me great pleasure to welcome him to tonight's Woo You event. Here are his financial disclosures. and all financial relationships have been mitigated. So I'm going to turn it over to you, and I will be back at the end.
And looking forward to presenting the very last lecture for Woo University. Can I get a woo woo? Woo woo! It's an honor. Thank you for bestowing that upon me, and thank you all for being here. We are going to talk real world, okay? This is what I'm thinking. You know what? I practice every day, just like you. I get up, put on my big boy pants. Sometimes I forget, just go in, wearing shorts, and I see patients. And I feel the number one thing that we have to focus on as optometrists, as clinicians, is the ocular surface. As we roll into 2025, we leave 2024 behind. The truth of the matter is this, is that every living, breathing person that walks into our door today needs our help. They need us to tell them what they should be doing. It's not a matter of us asking them, it's a matter of us telling them these are the things to help you improve the quality of your vision. So this to me is kind of a real world opportunity. I don't come from the dues reports, and I don't come from a lot of the science-based help, because let's be honest, people, most of your patients don't either. This is me. Here's my financial relationships. I'm still looking for some. I'm trying to get a couple pages. So if anybody has any, they want to hook me up, I appreciate it. But I work in Scottsdale, Arizona. And more importantly, like I said, I try to be real world. When patients ask me how I am, I tell them I have diarrhea. That there's nothing more real than that. What I should say is, I don't know, I'm surviving. How are you doing? You got to throw back at them. What we need to do is stop asking them questions, right? We need to start telling them things. But first things first, okay? We are living in a world of desiccating stress. Yeah, okay, I said it, life is stressful. And more importantly, though, everything that our patients are doing, everything, put yourself in your patient's shoes. I walk into the exam lane and my first thought is, were they watching Silo last night? Are they watching Yellowstone? Are they thinking the same thing I'm thinking? It's like we need more Beth and we need less Jamie, or we need more Beth beating up on Jamie. We need less cowboy stuff. And for those of you that live in, the Midwest and cowboy stuff's your lifestyle, that's good. But I'm sorry, it's not helping. Okay. How many people saw a disclaimer? Did you see that coming at the end? I think my point I'm trying to make here, people, is that we're spending so much time on our monitors, on our tablets. We're spending so much time on this bad boy right here. If you just updated it with the new AI, I have no idea what that's going to do for me, but I did. And so as this desiccating stress starts to happen, we look at this wheel, and it's phenomenal. Because think of every one of your patients, okay? We get blepharitis, allergies, contact lens wears, the environment, being on an airplane, right? More importantly, surgery, patients on medications, Sjogren's, all of this feeds in to this desiccating type of stress. We start to see tear cell hyperosmolarity, which causes cell damage, which causes apoptosis, which causes nerve stimulation, inflammation, causing more cytokines, causing more goblet cell loss, which is mucin, which then creates this instability of the tear film, which then causes inflammation and inspissus of the meibomian glands, which then causes tylosis and dropout. Bottom line here is this, people. At some point, you have to say enough's enough, okay? We need to go into the lane and say, I'm glad you're here today because these are the things that we need to do. And I want you just to take a second, okay? Some of you just ate dinner and you thought maybe I need to brush my teeth because I did. Some of you are driving home and you have this on in the background and you're probably not even listening. Some of you are probably watching, something on whatever's on Tuesday nights anymore. I don't even know, the YouTube. But the truth of the matter is that when we start thinking about our patients and we start thinking about everything that our patients are doing, is that they're coming in to see us because they need us to help them change the things they're doing. And so I want you to step back and think, what things do you do proactively and preventatively, right? You brush your teeth, right? You shower, you put on the lotion, it puts on the lotion. And men, gentlemen, if you're not putting hydrating lotion on your face, sorry, you're missing out. Okay? You're missing out. You're going to look like a couple of those guys from Yellowstone. Okay? Yeah. And I'm not talking about the men, I'm talking about the saddles. So, more importantly, what we're going to do for our patient's eyes is kind of like the same thing you do if you had hair, when you put conditioner on, or when you think about all the things you do to stop something from getting worse. This desiccating stress, inducing inflammation, losing cells, and causing changes to the quality of our patient's vision is where we start. Now, a patient comes into the lane and they ask, hey, I just thought I was here for an eye exam. And you're like, well, no, you're here for me to basically do an eye physical. You're here for me to tell you why, you're here actually. Because nobody wakes up in the morning and says, yay, I'm going to go get my eyes examined. No, they come in because they kind of feel like they have to. So we start triaging. We start asking questions. You can ask, how quickly or does your vision fluctuate? Do you see glare at nighttime? Are you thinking about blue blocking computer glasses? And if they say yes, then you say something like, those are hideous. Those are like contraception glasses. You might as well just stay in your mom's basement. But more importantly, you can ask things like, do your eyes itch? Do you feel your contacts? Okay. Contacts should be like underwear. You shouldn't know you have them on. Okay. It should be like socks. It should be like anything. You shouldn't be conscious of it. And if you are, then that's intolerance. And that means something's changed. So then we start thinking about risk factors like, do you smoke? Are you overwearing your contacts? Do you work in a really dry environment? Do you not get enough sleep? Are you stressed out? Hello, we all are. So then we start thinking you need to start doing some testing to basically figure out where you are. And we have a lot of opportunities to do that. Now, back in the day, we used to break these down into, is it evaporative or is it aqueous deficient? And from a real world perspective, my friends, I'm going to tell you this. It kind of doesn't matter anymore because almost everything is evaporative. If you think and truly believe, like, the data that supports the fact that over 85% of our patients have an evaporative aspect, then if you come at it from the evaporative aspect, then you start saying, let's look for some inflammatory aspect as well. From an inflammatory aspect, you can start thinking meibomian gland dysfunction and those changes. From the aqueous, you start thinking you can look at tear meniscus height, and all of these things play in between. The question is, how are you going to do it in your practice? What are you going to be able to incorporate into your lane to be able to enable you and help you help your patients? Because that's literally what it's all about. To me, you can start looking at symptoms by doing something like an OSDI or an OSDI-6. The speed test is 5 simple questions. It's the standardized patient evaluation of eye dryness. Or you can do a DEQ5, which is another one that Chalmers et al. These are all basically ways of doing representative, quantitative ways of looking at symptoms. And that's fine. Or you can just ask pertinent questions. Like, as we said before, do you feel like your vision fluctuates? Do you feel like if you blink, you see a little better? Do you ever feel a desire to put a drop in your eye? No, I don't. Really? Then why are you using drops? Have you ever heard of the term lumify? You have. Okay. Right? What does Visine mean to you? I mean, nobody just puts a drop in. It's like nobody drinks Pepto-Bismol because they think that pink peppermint flavor is kind of like festive. No, they do it because they feel they need it. So if you're putting drops in, your patient is basically symptomatic, and they're telling you, help me, doctor, help me. Now, we can do some point of care testing, and I'll be really honest with you, okay? Osmolarity testing, which is part of the Bausch plus Lomb purview now. It was purchased from them. I love osmolarity testing because when you have a high osmolarity, then there is absolutely 100% guarantee that this person's tear quality is crap. It's terrible. And the best way to think of it is this, is that, you know what? You can't have a false high. As my good friend Doug DeVries said, you can have false lows. You can water that thing down, but you can't de-water it to change the tears and make a false high. So it's either high or it's not. And the best analogy that I always love to use, and I actually oftentimes will tell my patients this, is that if you think about whether or not you're dehydrated, here in Arizona, in the desert, we have a lot of visitors and spring training players will come in, and in the urinals, ladies, that's where we stand to pee. In the urinals, in the locker rooms, there's a sign and it says, "Are you hydrated?" And it says, "What color is your pee?" Yeah, we're going Dr. Oz here, okay? And if it's, kind of like an amber, not amber, I don't know what amber is. I don't even know why I said that. If it's like a light yellow, then that's normal. If it's a pale yellow, almost white, you're too hydrated. But if it's that orangey color, then you're dehydrated. Oftentimes, I will tell my patients that their tears look like orange pee. Okay. And they get it. Okay. Some of them don't come back, but they get what I'm telling them. We need to change that. We can also look at MMP9s, okay, which is our metalloproteinases 9, which is basically just another kind of non-specific inflammatory mediator, which tells us there's inflammation in the eye. That's a little bit less, it's a little more ambiguous as to where that comes from. But what this is telling us is that something's not right. Now, when I talk about self-treating and I talk about patients that are already lubricating, to me, I hate the term artificial tear. I think an artificial tear is tantamount to confusion. Okay. You're basically telling your patient you're putting something in that's like a tear, but it's artificial. That's almost kind of like saying forever meat or beyond meat. It's just confusing. Nobody likes that, It's kind of like, no, it's not real. But what you're doing is you're keeping them lubricated. So these are lubricating drops. This is a perfect opportunity for our patients to basically just get something in their eye to be able to get momentary relief. For those of you that just had dinner, those of you maybe that just woke up, you put a mint in your mouth, it freshens things up for a few minutes, and then you know what? You feel like you need another one. Think about it when you're talking to your patients, you're empowering your patient to be able to put a momentary relief in their eye. Now, they're not all the same, and I don't think that you should tell patients, oh, here's a blue box, here's a green box. But you want to look for products that basically are going to not create blur, that are going to maybe add back a little bit of the oil they're missing, something that has like hyaluronic acid, which is great because that actually causes a thickening, or trehalose, which is an osmotic protectant. You want them to be preservative free. So look for specific ones that are going to help your patients, but just remind them that this isn't changing the course of the disease state. Staring at your monitor, being on an airplane, smoking cigarettes. I'm not quite sure about taking gummies, but then again, email me, ask me afterwards. I don't know. More importantly, the big thing that I think that we can start focusing on this year, as it's coming up to 2025, is lid structure and function. Too much coffee, another thing that dehydrates our patients, okay? To me, if you don't have some way of evaluating this in your practice, you know what? You could get something like the Ocu-Stick. Everybody hit me with that Ocu-Stick, okay? Oculus has this little knife and thing that you can put on there. It's kind of cool. I think sometimes patients like when you have a device that, for all intents and purposes, looks like you're kind of not sticking your finger in their eye. Back in the day, Johnson & Johnson had the Core lid evaluator, which you can see in the upper right-hand corner over there. It actually simulated the 3.0 PSI that you get when you blink. Okay, there's your fingers. If you notice, there's on the left-hand side, the cuticles look horrible. And then when you dim it out a little bit, the cuticles don't look as bad. Gentlemen, again, okay, get those lenses going there. Other things you can get in your practice to evaluate the lids is something like the Miverter. I love this thing, okay? The Miverter basically gives us that one-handed opportunity to flip the upper lid. You can see the meibomian glands. You can look for lost contact lenses that have fallen behind the eye. Oh my. Oh, that'd be cool. That'd be like, yeah, Wicked, right? We had an opportunity to see Wicked, and my wife wanted to see Gladiator 2. Epic fail. Epic fail. If you've seen Gladiator, you've seen Gladiator 2. Epic fail. But look how you can utilize this. My staff uses this. And my staff will be like, I looked under the upper lid, it's a kind of a weighted forceps. Basically, you put on those little silicone pads, which are removable. So look that up, Miverter, excellent thing. When we start thinking about evaluating the form or the function of the meibomian glands, there's a lot of different devices out there. And what's nice about these devices to bring into your practice is that it basically encourages your patients to be educated, to understand that there's something different. You show pictures. There's nothing that I love more than being able to look at a patient and say, this is normal, or this is what I anticipate, and this is what your eye looks like. Normal P is light yellow. Yours looks like an orange starburst. Okay, do as you will, my friend. Because when you show them and then you say, so this is what we're going to do to change it. To me, what I really think it does when you're talking to your patients and just kind of bringing things back to day-to-day life. Okay, I want to help you be able to work from home. I want to be able to help you when you bring it back that way and then say, this is what we need to do. And I always say we because believe it or not, we're in it together, my friends. You know, your staff. Have I ever told the story that I said that to a patient once? I go, all right, my friend. And she goes, we're not friends. And I go, excuse me? She goes, you just said friends. She goes, I have to see you. I don't want to see you. We're not friends. If you don't think I went out of my way to make that woman so freaking uncomfortable, you do not know me. Okay. And I think you guys know me. Okay. Yeah. So my friends, is that literally what we need to do is draw it back and say, this is what we're doing because they're going to call you or they're going to be invested in you. And to me, there's nothing better than being able to look at a patient and say, you know what, we have other things that we can do. We have other opportunities to change it. When you start looking at the meibomian glands, you know, these long acinous cells at the end there, they secrete the meibum. They're going to look tortuous. They're going to look, you know, kind of, basically truncated. They're going to, this is all the process of meibomian gland dysfunction. But the question is, at what point can we slow that process down? Or at what point can we tell patients, look, we need to start doing things a little bit differently? Some other things that we should look at when we think about the lids is that asking our patient a simple question, okay? And that question is, when do your eyes feel uncomfortable? For patients that are symptomatic, and if I can pause here for a second, is that I don't treat off of symptoms that are completely, I guess, congruous with dry eye, because I hate the term dry eye. I think it's an ocular surface. I think it's a dysfunctional tear. And so when patients say my eyes feel dry, I will basically say, well, what does that mean to you? Explain that. Okay. And if they say, well, in the morning when I first wake up, it's like, I can barely open my eyes. To me, when you first wake up, everything should be refreshed. I know most of you are like me. You wake up and you think, I can't wait to go to bed again, you know, but the eyes should feel more refreshed. So there's something called lid, you know, basically like when your lids don't seal properly. So we start looking at the bottom here. This is a patient of mine. And this was Don Korb basically talked about this, is that the lids basically kind of create an overhang, kind of like, you know, but there's a seal, right? So when you have lag ophthalmos, they kind of like don't close, but for people that have a lid seal problem, it's just not adhering. So there's a space there. So you have your patients gently close their eyes as if they're sleeping, and you take your transilluminator, and do you see all the light protruding from the bottom of this patient's eye? I mean, this is classic lid seal issues. Okay, and you can see in the upper right hand side too. So you know there's something called sleep tight, sleep bright. It's basically a adhesive tape that your patients can wear at night. It's hypoallergenic. It comes off quite easily. They can wear sleep goggles, which are not comfortable, but what they need to do is keep those sealed. Okay. So, you know, the other thing that I will do is that I will say, okay, you know, when patients say, my eyes don't feel dry. I don't have any dry eye issues. I'll say, well, then what brought you in today? Well, I thought it was time, or I need to update my prescription. And then when I look at the tears and when I start looking at the assessment, this is when I get to say, well, these are some of the reasons why you're not functioning as well. Or these are some of the reasons why you're not seeing quite as comfortably as you think you should. Now, it's a beautiful, easy thing when you stain a patient and you see basically 3+ SBK. I'll be honest with you, this thing, that central SPK like that, and that almost looks like neurotrophic keratitis to me. Okay. And you're right. You're like, dude, you put the slides in there. I'm like, yeah, you're right. Okay. You also can see, the oil glands that are kind of illuminated there. It looks like they're wearing false eyelashes. There's a lot going on in this picture. But if you are going to stain patients, and honestly, you know what? In real world, you'd love to sit there and say you're staining every patient, but maybe you don't get to. But if you suspect that there is corneal apoptosis and there's corneal issues, is you put some fluorescein stain in, and you could use fluoresce. You could just use fluorescein strips. You got to wait a minimum of 90 seconds, 90 seconds to 2 minutes. Okay. Anything shy of that, it's basically just superficial and washing off. Okay. Remember, the stain is kind of get in between the cells there and the epithelial tissue. So you want to see that get in there. All right. So wait on that. Okay. Something else as we're looking at our patients is, to me, when I walk into a lane, and, they're like, hey, how are you? And I've already told you how I told them I am. I'm looking at the patient. Okay. I subscribe to the LLPP, look, lift, pull, push. And I'm looking at that patient and I'm looking for that red ruddiness to their cheeks and their nose. For the females, that's not quite as obvious because they don't have a lot of that bulbous, but you can see the larger pores and maybe a little bit of the neovascularization. When I see ocular rosacea, my mind immediately goes to meibomian gland dysfunction, ocular rosacea blepharitis. I started thinking about all the things combined with that. And my diagnosis is oftentimes Demodex, MGD, dry eye, keratoconjunctivitis sicca, because almost always, the vast majority of these patients significantly have those effects. And if they don't have them, they're going to. So a diagnosis or looking at a patient with rosacea, your mindset shouldn't be, you know what? I take that back. Every time you walk into the lane, your mindset should be, prove to me that you have a perfect, ideal ocular surface. Prove to me you do, as opposed to prove to me you don't. Because I walk into a lane thinking, what am I going to do with this patient today? Which is why I write a lot of prescriptions, which is why I do a lot of treatments, which is why I spend a lot of time. And well, I digress. I don't spend a lot of time. I do almost all of my talk at the slit lamp, and I'm like, shh, no talking. And I get to do all the talking. And when they start talking, I'm like, not listening. Is that I spend time explaining to patients what I'm seeing, how it's going to affect them, and then saying, but fortunately, we have something to manage it. And I'm already thinking of all the different options that we have, And to me, when you start thinking about a strategy for helping these patients, it's like looking at this patient right here has a lot of mascara and a lot of makeup on. I'm thinking, gosh, I wish I would have, learned more from like Selena McGee's, eye makeup lecture that I listened to. Is like talking to patients about how they can manage these things so their eye looks as freaking white as that. Look at that. That is impressive, right? That looks healthy. That's what our patients want. And so we have to tell them. We have to give them that. I told you, look. Hey, the second thing in that would be look down. Hey, this is 2024, my friends. And if you're not thinking about Demodex blepharitis, if you're not thinking, how can I get rid of the collarettes? And you know what? I'm not going to lie to you. I think one collarette is too many. Because, I oftentimes will put things in perspective for myself. If I walked into a doctor's office and I had my eyes coated with all of that shite, because let's be honest, people, okay? It's shite, okay? It's waxy, buildup, it's caca. They're hardened secretions that basically end up at the base of the lash. How do we identify these things? We just tell them to look down. And you know what? Crank up your mag a little bit so you can see them. And what I will do is I'll tell a patient, I go, what, I'm noticing that you have a little blepharitis. Okay. There's a little bit of some debris or inflammation on your lids. So we need to talk about that a little bit. Okay. When we start looking at that, I tell them, look, this is predicated or based on the fact that you have a over or an infestation of little mites. And I always tell patients, look, we have bacteria, we have viruses, We have lots of, other things that are in our eye, but we also have little parasites that can overpopulate. You were born this way. Everybody has it. It's all good. Okay. But we now have a treatment to be able to manage this. Remember, friends, okay, there's folliculum and there's brevis. The brevis are tiny. The brevis are believed to be in the sebaceous glands. They're believed to be maybe associated with a little bit with meibomian gland dysfunction or the rosacea that we see along the lids here or the cheeks. But the folliculum are the ones that are in the follicles. And in that case, what we can do is we can manage them by eradicating them. And I get it. We think about the lid wipes and we think about, getting the debris off. And, BlephX has always been a really kind of stalwart, opportunities by Dr. Reinerson. He's actually come up with another treatment called Revi, REVVE. You should look it up. It's a way to basically go in and just kind of get rid of the biofilm on the tissue. But think of Demodex as little parasites that eat dead skin and live off oils. So the wipes are going to help get rid of some of their food source. But the bigger thing they do is they have claws that create little microabrasions. They induce inflammation and irritation along the lid margin. But I also firmly believe that they're the root cause for things like hordeolums. They have a unique bacteria inside there. It's a bacillus, which is not, kind of a part of our normal genome. But basically what they have is a specific bacteria that when they explode, they leave behind. And think about that. Saponification along your lid margin. Okay. Irritation along there. Okay. A lot of these things are because of it. So now ask yourself, if we know that all this crap is happening at our patient's lid margin and we're creating meibum so that we can help with our desiccating stresses, how are we not helping our patients? How are we not helping our patients by not doing that? Right? Right. You may say, oh, but Mark, the PAs, and oh, Mark, it's such a no, no, stop. Okay. We're a team. You, your staff, everybody, we're a team. Okay. And what that basically means is you got to make the effort. I could just, again, imagine going to a doctor's office where they basically say to you, well, we have a treatment, but you don't really seem that bothered. And to be quite honest with you, it's kind of a pain in the ass for us to do it, so we don't want to. It reminds me of Bonquiqui. And if you don't know Bonquiqui, then I'm going to tell you. Security, okay? That's it, right there. So we have tons of different pictures. We have tons of different opportunities to treat this, but lotilaner right now gets in there. Gets into the GABA-gated channels of the mite. It eradicates them by paralyzing them. It is a novel treatment. Okay, phenomenal. Now you may say, what about the evaporation? As I mentioned before, okay, 86% is evaporative, 14% is aqueous deficient. When we start seeing that evaporation exceeds the total supply, the stress, the tissue damage, all the things we just talked about. Well, meibomian gland dysfunction is quite easily treated in our practice, and I'm going to kind of go through it relatively quickly. But one of the things we can talk to patients about is lifestyle. Okay. Blink more. 20, because it feels good. It feels good. Blink, blink, blink. Blink more. Okay. Talk to them about utilizing tear supplementation. Keep a little bottle next to you. Put it in when you think about it. Heating up the meibomian glands, moisture chambers, but also lid hygiene. So, this is a and treatments. This is not an or treatment. This isn't, well, we can do this or. What I tell patients is, and again, draw it back to what's important. The glands along your lid margin are getting, inspissated or clogged, so we need to heat them up a little bit to melt them. Here's something you can do at home. Okay? When we start thinking about, the Tear Film and Ocular Surface Society, their lifestyle discussions was contact lenses, maybe change out your patient's contact lenses, talking to them about digital environment. But the bigger things is that, we can sit here and talk to patients about this, changing their nutrition, maybe moving a fan away from them. But one of the things that I feel is really important for us to do is to not try to have people change who they are, is to try to do things to help them stay who they are. And what I mean by that is that if you live in Arizona and if you don't have a fan going in your house during the summertime, you're screwed. So instead of saying don't use a fan, say I know you're going to use a fan, so let's put that on. If you live in the winter, like right now, here we are Tuesday night, and it's dry AF, then you know what? Then use a humidifier. Things like that we can help our patients with. Something else is that when you see the capped glands, when you see glands that are inspissated, think about doing debridements in your practice. Go in there and scrape the keratin away. Use something like microbluffer exfoliation. If you don't have it, then you can get one, or you can explain to patients somebody who does have it, and so that you can get those glands opening up a little bit. Because using a warm compress at home is nice, but I'm not going to lie to you people, okay? The vast majority of your patients don't do it, okay? The adherence to doing these things is not great. And if there's a lot of inflammation, right, a lot of rosacea looking there, then sometimes that exacerbates it a little bit. So as much as I know we love talking to patients about warm compresses, make sure that when you do talk to them about it, is that they need moist heat. They need to keep it on there for at least 10 minutes. And if it feels good, then keep doing it. If it feels worse, then stop doing it. Okay. I talked about the lubricating drops, moisture chambers or something as well as, using the lid hygiene. But only 55% of our patients are compliant. Okay. And I don't like the word compliant because that implies that they don't want to do it. I like the word adherent. And adherent, for all intents and purposes, means that they start losing sight of doing these things. A great analogy to me is, for those of you that have a gym membership or have a Peloton bike, and if you have a Peloton bike and you're not riding it, shame, shame, shame. Okay? So for those people, what I would suggest you do is think to yourself, why did I buy this? I bought this because I want to get healthy, because I want to look good, because I want to make my booty bump. Well, if that's the case, then you know what? Figure out how to become more adherent. Or maybe what you need is somebody to remind you. So for these patients, a vast majority of a lot of these things that I would tell you to do is bring them back 3 to 6 months. And at the very least, it's just because, hey, are you doing the warm compresses? Because you probably should. Okay. Or maybe meet them somewhere where it's like once a week. Now, I'm not saying meet them once a week. I'm saying just do them once a week. Right. Now, a way of getting around all that adherence stuff is to do something like an in-office procedure. You want 100%, perfect, then do it in the office. Okay. So we talked about the microbluffer exfoliation. We'll talk a little bit about probing, which I will not do, but there's thermal treatments and other treatments we can do. Okay. So for example, microbluffer exfoliation or the zest treatment, both of these things you can do in your practice to help basically clean out and remove a lot of the biofilm from your patient's lids. You see somebody who has a tremendous amount of that, then I would advocate you do that there. When you start thinking about probing, this was something Maskin did. Probing actually does help to kind of clear out the gland. I drink way too much coffee. Not something that I can do, but there has been significant improvement in the meibomian glands. But we have other treatments. So an automated vector thermal pulsation, this is a device kind of like, utilized by iLux. You can do a I'm sorry, not iLux. Gosh, I'm losing my mind here. Doesn't matter. Okay. The iLux system basically is the semi-automated thermal pulsation procedure. And literally what this is a handheld device. It has a camera associated with it too, so you can videotape it. This is from Alcon. And it's an excellent way of doing handheld treatment utilizing a light as a heating device. Another practice that you could do in your practice is using intelligent heat manual expression. This is something that is done by, Sight Sciences. This is their treatment device. It's an open, patients can blink, they can work through it. They're working through some newer things here as an option for you to be able to do in the practice to kind of heat up the glands and get those working. But, there was a study that was done. It's called the Sahara study. And what they were doing is one treatment of using the TearCare system here to kind of utilize the glands, and the lippy scan or the lippy view was the one before. I know. Mind fart. Hang on 1 second. More coffee. Tuesday nights. Am I right, people? But nobody's really doing the lippy scan anymore. So but a lippy view. But the tear care system here is they took one treatment of this and compared it against 6 months of utilizing Restasis. And then they did one more treatment to those patients. And so at 1 month, they evaluated them. And you may say, well, Restasis is an anti-inflammatory. This is more for evaporation of meibomian gland dysfunction. But what they found at the end of the study, early data, because they haven't concluded the full data at the 6 month and the 1 year mark, is that patients had significant improvement in tear breakup time, as you would think, but they were non-inferior in Schirmer's and in symptoms. So in that case, those patients did really, really well. Other treatments to lower the inflammation would be something like intense pulse light, and we see intense pulse light or IPLs also help with chalazion treatments because it's incision-free, injection-free, scar-free treatments. You know, people like Laura Perriman have done some phenomenal opportunities to demonstrate how well you can utilize that. Something else to bring in your practice would be like LLT therapy or radio frequency, and often some of the other IPL devices have the same thing associated with it. Although there is no peer literature examining their efficacy in the treatment of meibomian glands, but what it does is it reduces a little bit of the inflammation that can cause some of those changes. We have new things in the pipeline. You know, we talked about these Keralytics. Azura out of Australia is in their phase 3 trials, which breaks the disulfide bonds, creating the keratin, which can open up those meibomian glands. A lot of people think this might have something to do with Demodex again, building those keratin bonds. We see significant improvement there. There's a 2% glucocorticoid cream. This is from Axero Vision, and they're in their phase 2 clinical trials. And what they're showing here is that they've improved in both signs and symptoms of dry disease associated with meibomian gland dysfunction. So an anti-inflammatory medication. Rinsada is out there, you know, right now, which is kind of cleaning out the biofilm. In other words, we're talking about meibomian gland dysfunction. You start thinking about like BESTO, bugs, enzymes, inflammation, stasis, temperature, obstruction. Laura Perriman came up with this. The woman's brilliant. Okay, she has great songs and everything too. But if you think about it, here's your BESTO, your bacterial burden, right? IPL, hypochlorous acid, something like lotilaner. For your enzymatic, you can start using anti-inflammatories, IPL. Okay, for your inflammation, almost everything that's described here. For your stasis, thermal pulsation, or IPL. For temperature, you start thinking about anti-inflammatory medications, and the obstruction goes along the same lines there. Okay, so treating that BESTO. Other things to think about is interventional treatment like neurostimulation. Okay, we have one now that's a nasal spray. There's going to be 2 coming out in 2025, which work on the corneal surface, work on the TRP8 receptors or the RASP inhibitors. And this is a whole different neural stimulation or neural activation that we're going to be able to use for our patients. If you're not using amniotic membranes, whether it be the dry form or the cryopreserved form, to reduce that inflammatory load, to help kind of reset the cells, to kind of start thinking back, maybe even managing NK, then you're missing out. Long-term, things like autologous serum to bring back the enzymes and to bring back some of the proteins, all the nutrients of the 2,000 things that are missing from your own patient's tears. These are things to start putting in at the back end, to not forget about. You have a patient who has lots of stain and no pain, blurred vision, hazy vision. Okay, start thinking neurotrophic keratitis, and you start thinking I should be using Stenogen BKG BJ a little bit sooner. I also think that we don't utilize topical steroids enough. Okay, these quell inflammation, these make our patients feel happy. Okay, this is like Jello pudding, it's like the Jello pudding that we have at the hospital. Okay, too soon? Was that too soon, people? But they provide relief. So short-term use, but even something like Isuvis, okay? Low-dose loteprednol, which is indicated for dry eye flares. Why would you not put that in your patient's hand? Why would you not give them that? Prescribe it for them and say, hey, I'm going to give you something to help you manage the condition. To me, that's like therapy in a bottle in their house, by their bed, wherever they're putting it, you know, then they're living their best life. Okay. To me, one of the things that I love to do is to be able to have a prescription with my name in there. So when they're thinking, oh, this is something that's going to help me. But unless you make the effort to do it, it's not going to. Now you may say, what about long-term? Long-term interventional is when we start thinking about things like cyclosporin. Okay. We know that it blocks T cell activation. We know that patients that need long-term, well, almost every one of our patients right now needs some form of long-term. Go back and look at those risk factors. Are they diabetic? Have they had refractive surgery? Do they have cataract surgery? Are they somebody who has rosacea? And say, why am I not doing something every day to manage it? Kind of like flossing your teeth. We know that, there's different cyclosporins out there now. We have 0.05%, which I don't really ascribe to as much because we have 0.09, we have 0.1% as well. So we have different ones out there. Lifitegrast is unique. It was engineered to mimic the ICAMs. It was engineered specifically for the eyes. Okay, so you have cyclosporin, you have lifitegrast, and start looking for those inflammatory patients with some injection who have a significant amount of meibomian gland dysfunction, and just having them doing something humming in the background. These are going to be patients for life. And when I talk to them, I tell them that. I go, look, you know what? I'm going to start you on a drop. It's twice a day. Okay. Because I want you to be able to do X, Y, or Z. For fluorohexyloctane, if you're not using Mibo right now, then you're missing out as well. Super comfortable drop, lasts up to 8 hours. Okay. More importantly, what it does is it kind of creates that barrier. So for our evaporative patients, this is a great drug to use on younger patients because it's tiny, comes in a microdose, and it just literally doesn't penetrate. Any patient who says, well, I'm allergic to it, can't be. Okay, it's water-free, it's preservative-free, it's steroid-free. It's not free, but for some patients, it's free. So again, don't prescribe based on what you think you might be using. We have new cross-link hyaluronic acid gel that creates a punctal plug. When I see a plug now, or if I see a patient who's extremely aqueous deficient, very low tear meniscus height, then I think, you know what, we got to keep the tears they're making in their eye longer. I tried to quell the inflammation as much as possible, but a true Sjogren's type patient, you know what, so this is Lacrophyll, and this works phenomenally because it forms to the shape of your patient's puncta. It lasts for about 6 months. I was part of the clinical trials, and one of the things that I was doing was evacuating these to remove them to show how easy it can be done. And it's great. I mean, just a great opportunity. And then there's also scleral lenses, which I'm going to leave right there because, yeah, I don't know much about scleral lenses, but I think at Woo U, you would if you did study it more. And then there's also supplements. There's a new one that just came out from Bausch and Lomb. It's the Blink Nutrition, which is a little bit different formulation. It's over the counter. I know a lot of you probably sell them in your practice. But to me, again, this is like cyclosporin or lifitegrast. This is like using a lubricating drop. This is something humming in the background, but your patients will oftentimes need something immediate and they'll want something. So that's where doing like an in-office treatment and also talking to them about those concurrent things that they can be doing to get those glands working better. I mentioned before about, there's some new studies and things that came out. This was a study that was done. It was a switch study Josh Johnson did where he demonstrated that patients who were on Restasis, who were having issues with Restasis, they switched them to a 0.09% to Cequa. Most reported that their eyes felt more comfortable after 4 weeks, and more importantly, saw a statistically significant improvement in corneal staining. So 0.05% Restasis, I think, had a good run, but we have better cyclosporins out there. And if you're not doing 0.09%, with the NCell technology, or if you're not looking at 0.1% with the unique vehicle that comes in, then you're totally missing out. Okay. And lastly, let's keep it real. Okay. There's inflammation and there's obstruction. And I hope throughout this whole course of this rapid fire discussion for your last just kind of ocular surface disease lecture for the year, the point I'm trying to make is that we have to do something. And I will tell patients, I'll say, look, your glands are obstructed, but there's also inflammation. This is what we need to do here, and this is what we need to do there. Okay, so this becomes a step-by-step approach. asking the questions, looking for the lid seal, maybe lid wiper epitheliopathy, which we never even talked about, thinking about the line of marks when your patient's putting on makeup. Yeah, I listened to some of the stuff. Okay. Talking about how Botox and fillers can affect your patient's eyes and blink and all those other things. And then pause and just ask yourself, what else did I miss? What else can I do to help my patient? Because it's not all just you're hearing your patient's complaints. It's about what you can do to help your patients. So in a real world communication, a real world approach, it's like, I'm glad you came in today because these are the things that I'm going to help you do. And by bringing them back to reinforce this, it helps with that, adherence to the treatments that you want to do. So hopefully you guys got some thought, some juices flowing, thinking about what you can do, how you can bring it into practice, and I will be happy to answer any questions that you may have.